Welcome to another episode of Tell Us More About That. Today we have
Bennett Harris. He's out of Asheville, North Carolina. He is a psychiatric physician's assistant, an executive functioning coach, and an LCMHC, which here in North Carolina is a licensed clinical mental health counselor. In Illinois, he'd be a licensed clinical practicing counselor.
There you go.
Yes.
Yeah, so we just wrapped the conversation with him. It was very informative. ADHD that's the one we've gotten the most requests for people from I guess listeners, or just people who have submitted us inquiries online about asking if we can have somebody come on and specifically talk about ADHD in adults. Mm-hmm. And we've also had some requests about ADHD diverse, or the difference between how it presents in women and men. So we touched on that a little bit, touched on common medications, touched on interventions that are not requiring medication. Mm-hmm. And then also the impact of coaching. So lots of different routes and directions that we took the conversation, but it was very, very informative.
Yeah. You'll hear a lot of brain talk. Neuroscience, so hope you're ready for that.
Yeah, but he does a good job of making it approachable, and I think if you have ADHD or you have someone in your life that does, or honestly, even if you don't have it, I think this is a really helpful conversation to understand, what's going on in someone's brain that causes them to be able to focus, and what's going on in people's brains when they struggle, not only to focus, but to find the energy to get up and do the task. Mm-hmm. So it's been super enlightening discussion. So we think you'll enjoy it. He
mentioned that ADHD isn't a knowing illness, it's a doing issue.
Yeah. Yeah, that's a really good point that he made too. He said a lot of the times people with ADHD come in and they're the ones that, and this rang true to me, they do all the research. They know everything there is to know about X. It's just getting them to actually get up and do the thing. Mm-hmm. So it's that catalyst for what we were calling motivation, and then now we will stop using that term based on the discussion. But awesome conversation with Bennett. So we're excited for you to listen in. All right. Welcome back to another episode of Tell Us More About That. Today we have Bennett Harris. Bennett Harris I found on LinkedIn. Shocker. I think that's how I found most of our guests. But looking for somebody who specialized in ADHD, and Bennett's experience and specializations run the gamut, not just ADHD, and I'll give him a chance to introduce himself here in a second. But he was generous enough to carve out some time to have a conversation with us this morning. So welcome to the podcast, Bennett.
Thanks, guys. Thanks for having me on.
Yeah, appreciate it. Bennett's based out of, we are in Wilmington, North Carolina, and Bennett is in Asheville, which is on the other side of the state in the mountains. So Bennett, if you would you introduce yourself for the audience?
Yes. So I'm Bennett Harris. I'm a licensed clinical mental health counselor, as well as a psychiatric physician assistant, specializing in working with the neurodivergent population here in Asheville. So I do quite a bit of psychiatric med management, as well as psychotherapy, and some ADHD or executive functioning skills coaching here. So the approach is pretty nuanced and holistic. So we don't just focus on the medications that might be helpful with it, but there's a pretty long, extensive list of things that people can be doing to help with the management of ADHD.
Okay. Yeah, and that makes a lot of sense. Yeah. I know this topic is near and dear to both Jen and I, but also everybody, I feel like at this point in time, knows someone who has ADHD, or at least self-diagnosed ADHD, so we'll get into that a little bit as well. But I think the easiest way to maybe get started on this is, can you give us kind of your understanding and definition of, I guess, what ADHD is and really what ADHD is not?
Mm-hmm, sure. Well, if you look globally at the numbers, it's somewhere between 10 and 13% of the population around the world could be diagnosed with ADHD, irrespective of where they live. So 10 to 13% of the population. So That's first of all, that's very interesting because I don't know if you've ever read the book Driven to Distraction by Radian Hallowell. It's a really kind of a classic book on ADHD. But they do touch on this idea that selective attention or varied attention is part of it could be due to our culture. But when you look at crunch the numbers, that doesn't actually seem to be accurate because you've got lots of places in the world where people they don't have the same access to tech that we have here or apps and social media. And yet still you see roughly the same numbers in terms of how endemic it is in a population. So, I mean, obviously, there's the acronym ADHD, attention deficit hyperactivity disorder. And, probably until about 15, 20 years ago, it was just called attention deficit disorder. And these things have to be observable. So I know we might touch on something called rejection-sensitive dysphoria here in a little bit if you guys want to, but it's not a diagnostic criteria of ADHD because you can't see that. You can't see internal subjective states. So everything that we use to diagnose somebody with that has ADHD has to be observable. So the observable symptoms, of course, inattentiveness. So like, how do we observe that? If you're watching a kid in third grade and he's just kind of dozing off, and the teacher's talking to him, and he seems not to be responsive or answering that, you can say, there it is, inattentiveness. I can see that. Mm-hmm. Right? Hyperactivity. Somebody can't sit still. Very easily observable. Impulsivity, somebody's cutting people off when they're talking, or just can't seem to keep something in. I've got to let everybody know regardless of the situation I'm in. Those are easily observable phenomenon, whereas some of the more nuanced emotional things that we know that go with ADHD as well, they're not. So we don't use those to diagnose per se, although they are typically present in the vast majority of folks with ADHD. And VAST is actually a new acronym that we use to describe ADHD. I think it's probably a little bit more accurate. Have you guys heard this acronym before?
No.
It stands for variable attention stimulus trait.
Hmm.
So we call it a disorder, and I think we'd be right to. But I don't want to get too far ahead with that. We can touch on the VAST or the variable attention stimulus trait a little bit later on. So what is it? Perhaps it's genetic. If it is, it's polygenetic. They've identified probably over 15 or 20 different genetic markers, but there's not one that's pathognomonic, meaning we can't, in medicine, that's a fancy way of saying we can point at that thing and say, if you have that, it's unmistakable. It's 100% certain that you're going to have a particular disorder or disease, much like a bullseye lesion from Lyme disease. If you see that it's unmistakable, it's pathognomonic. In ADHD, we don't have that. So it could be genetic. If it is, it's polygenetic.
What most people, when they think about ADHD, they either think about it from a personal kind of experience that they've had with it, whether they've been diagnosed with it and they're medicated or they're going through some type of other type of treatment, or they know someone who's just like textbook what we would define that friend as the one with ADHD type thing.
Sure.
So where does it actually tend to present itself where people go in and seek out a formal diagnosis? Is it more like their parents bringing them in as kids, or are we seeing a fluctuation in adults coming in and asking questions and getting a later in life diagnosis?
Well, in terms of being diagnosed at an early age, we know that it is, I hate to call it a disorder. I'd rather call it a trait, but we'll get to that. Sorry. It starts. Nobody knows when it starts, but we've observed these inattentive and impulsive type behaviors in kids that are very young, under the age of 2. So it's a lifelong trait or disorder, if you will. And whether or not you're diagnosed in childhood has a lot to do with how self-aware your parents are. So if the parents are seeing something that's really causing what in the counseling and psychiatry world we call clinically significant impairment, then it's the onus is going to be on them. Like obviously, a child is 4 years old is not going to walk into his class and say, "Hey, I think I need a psychological evaluation." Right? That you're never going to see that. But whether it's diagnosed in a child, an adolescent, teenager, or an adult, you're always going to see what we call clinically significant impairment. So you might have a friend like, "Oh, Jason, that's Jason being Jason. He's real impulsive," or you're talking to him. It seems like he's out to lunch. He's staring out the window all the time. But it has to cause impairment in one or more major life domains, such as social or occupational functioning, domestic functioning. So there has to be some real disruption to your life that it's causing in order to make the diagnosis.
Okay.
At one point, wasn't it, and this maybe like 20 years ago, I feel like ADD or ADHD had to be, I'm going to air quote, had to be diagnosed or observed by the age of like 7 or 8. And I assume that has changed a lot by now, but
Um, we so a lot of people who diagnose ADHD like to see some sort of developmental history of symptoms, before the age of I think it's 8.
okay,
I could be wrong on that, but it's not imperative to the diagnosis.
okay,
So a lot of times you'll have adults coming in and they'll say, well, maybe I had some inattentiveness or some impulsivity as a kid, but I got by okay. And what happens is a new level of external stressors tends to unmask it.
Hmm.
mm-hmm.
So where coping skills are exceeded by the external stressors, particularly, that's when you really start to see symptoms pop up. And that's why a lot of kids won't get diagnosed until at least middle school, if not high school, and then into college, obviously, because the material gets more dense, things get more difficult. The executive functioning toolkit is taxed much more significantly. So you see this sort of unmasking of the symptoms.
Yeah, I am going through my own personal potential ADHD journey, and I'm a school counselor, so I've worked with high school age kids, and I'm in an elementary school right now, and I have a hard time kind of pathologizing ADHD, whereas I really like that we're trying to call it a trait rather than a disorder. It's just sort of like differences in how brains are working and processing, but I I see a lot of observable ADHD, and it is a word that is just, or a diagnosis that is just sort of thrown around haphazardly in a school setting. So I I love that you have this approach that is, there's the testing, there's the medication, there's the other interventions and executive functioning coaching. I mean, I think that is, like you said, the whole kind of more holistic, well-rounded approach to supporting someone that may have ADHD.
Yeah, exactly. And if you think about it, let's go back to this idea that it's not observable until the external stressors exceed the skill level of that given individual. Well, if you think about that, there might have been a life in either another reality or another, maybe in this reality, but in a different country, where that person may have never exhibited the signs of the symptoms of ADHD or variable attention stimulus trait. And the question is why? And I would say that because the environment was conducive to supporting the trait. So
Mm.
one of the reasons that I have a hard time calling it a disorder, especially around people who are really interested in, in self-growth, exploration, learning like how to work with what it is, this trait that they have. It's just not very empowering to call it disorder. So if you were to if you had type 2 diabetes, right? If you had this really high A1C, and you went to the grocery store this afternoon and you went shopping, whether you were there or whether you were sitting at home, you would have type 2 diabetes. You go to work, it's there. You go to a movie theater, it's there. Now, you might do some sort of lifestyle changes or get on metformin or some medication to help lower your A1C, and you would no longer meet that diagnosis. But the environment has nothing to do with it.
Mm-hmm.
Whereas in ADHD, some people, or VAST, some people in given environments will be completely asymptomatic. And in other environments, they will have lots and lots of symptoms. So it's a lot more like a trait in the sense that if a toucan was taken out of the rainforest and put in the middle of the Sahara Desert, the beak that was a highly specialized tool would then look like a liability. And that has everything to do with the environment. And that is the definition of a trait.
Hmm.
That's a really interesting way to look at it, and I had not considered it in that way before this. I really like that kind of perspective of it.
Yeah. Well, we can go a little deeper. We can go into the neuroscience for a second. So if you look at somebody who has ADHD or VAST, and they're what we would call symptomatic. So they're impulsive, they're hyperactive, or they're zoning out a lot. And you put them under an fMRI, which gives us these minute-to-minute snapshots of what's going on inside their brain. You see this function of the brain. It's generated by about 4 or 5 different structures between the prefrontal cortex and the midbrain. It's called you guys might have heard of it. It's called the default mode network. So the default mode network is necessary for creating your biographical knowledge, autobiographical knowledge. So everything that you think you are, the Bennettness of Bennett, is created by this default mode network. So it's the ego, it's a sense of self, right? So people with ADHD, especially when they're symptomatic, this default mode network is highly active, a lot more active than it is in somebody who's not neurodivergent. So if this thing is cranking all the time, just boom, 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 cranking, 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 and this person's past is riddled with unmet expectations, faux pas, things that they said that embarrassed them, and I could go on and on. And those are also really ever present on the front of their mind. Then this is going to be a very noisy place to live, and it's going to cause symptoms. So part of treating ADHD is emotional regulation, which is an executive functioning skill. And the chief aim of that is to inhibit the default mode network. But that actually becomes a sticky situation because the default mode network is also the birthplace of creative, inspirational, intuitive thought. And that's why you see so many people who have ADHD or VAST being highly creative people, artists, writers. It goes on and on.
Yeah.
So you want to be able to throttle it back when it's causing you trouble, and then other times you want to be able to really let it go. And you've got to be able to differentiate between the two, and that's actually part of the treatment of ADHD, especially in adults.
Yeah. So do you use like DBT for emotional regulation, or?
The best way to have somebody become emotionally regulated, in my opinion, my experience that has ADHD, is turning the default mode network off.
Okay.
And there's a couple different ways you can do that. So if you have somebody with ADHD sitting in a room and you say, okay, I want you to think about something that's really been bothering you, something you've been stewing on that you're ruminating over, it doesn't take long for them to find something. You have them close their eyes and do something as simple as a Brahmari pranayama breath, a bumblebee breath, so a yogic breath. The second they start doing this, the thought, they can't hold it. They will not. You could try this yourself. You can think about anything you want, somebody's face, something that happened last week, what you had for dinner last night. You start this breath, it's gone. So it inhibits the default mode network. Another way you could do that is you could strengthen the connection between the cerebellum and the prefrontal cortex. And that cerebellum is necessary for balance and coordination and what we call proprioception, or the ability to understand your body in space, right? So very simple things like standing on one foot with your eyes closed. So a lot of the things that I prescribe are very physical or somatic in nature, and they oftentimes involve some sort of coordinated breath or something that involves balance.
I love that.
Yeah.
Bringing your body into the brain and connecting it there.
That's interesting. We had a guest on a few weeks back where we talked about OCD and this concept of like ruminating thoughts and things along those lines. Is that something that you see common in treatment for those issues as well?
Yes, there is a lot of overlap between anxiety and generalized anxiety / panic disorder, bipolar disorder, OCD, and ADHD. And this sort of obsessive ruminating, turning over of things in the mind is a big part of all of that. And if you didn't want to take medication, let's say you say to yourself, God, I don't want to start the med route just yet. What else could I do? Learning how to quiet the default mode network on a regular basis, on a scheduled, disciplined basis, is really important, because MIT, you can look this up, MIT is not known as a bastion of psychological research, but they have taken a keen and peculiar interest in ADHD brains. So they do longitudinal studies of people with ADHD, and they do these MRI scans periodically. And somewhere around the age of, 17 or 18, there is a percentage of people who will, quote unquote, not have ADHD anymore. It will look as if they don't. Now, we know that that's probably just because they've, what could be the reason, right? Did they change their diet? Did they go to a really good therapist? Is it a supplement they're taking? Is it meds? Is it really good counseling? Nobody knows exactly what it is, but we know that they don't exhibit the signs and the symptoms of ADHD. And the one thing that they all have in common is the default mode activity tends to be at much lower, revving at a much lower RPM, if you will, than of people who are symptomatic.
Hmm. Is that based on any type of intervention that they experienced that allowed them to quiet that down, or is it
They don't
just
know.
okay?
They don't know. They just come in and they do the scans. But they
Interesting.
do see that a small percentage of people, when they move into young adulthood, they just seem to be a lot less symptomatic, and some of them asymptomatic.
Okay.
But these are large studies, longitudinal observations, so they're not really trying to um, inject any kind of interventions.
Sure. Have you seen that in long-term studies along those lines where if you intentionally intervene with some of these strategies that you're talking about of teaching people strategies how to implement the balance and the breathing exercises, that over time it starts to become an automatic process for them, or
Yeah.
is it
Okay.
okay?
So you won't see those studies, and the reason you won't is because there's no money in that.
Yeah.
Um, However, anecdotally, I see it all the time. But the other thing that you can um, read about is there is a in Europe. I think they do it in most Western European countries. I know they do it in Great Britain. It's starting to catch on in the United States. There's a program for kids called Mind Up.
Oh yeah.
Yeah, and a big part of that is meditation and breath work.
Yeah. The school that I work at, the counselor before me was working with the Mind Up curriculum, and I think we bought a book.
Mm-hmm.
So I skimmed through it a little bit, but it's mindfulness, meditation, breath work, and it's kids kind of understanding their brain a bit differently at a younger
Mhm.
age. Yeah.
Yeah, and you were in speaking of OCD, kind of go back to that for a second. So you have another network in your brain besides the another one that's very important to focus and concentration, and it's called the task positive network. And the task positive network kicks on when a person is engaged in something that's pretty complex. So whether you're standing on one foot with your eyes closed, task positive network, sending an email that's pretty involved at work where you've got to really be doing a lot in your head, a lot of mental calculus, task positive network. So in the person who doesn't have ADHD, this is how they work. So here's the task positive network. Here's the default mode network. They work like this in most people, which is to say when one is inhibited, the other is excited, right?
Mm-hmm.
So this one's on, this one shuts down, vice versa. Person with ADHD, we know that they look a lot more like this. So that default mode network is always acting like an intrusive sort of force. So this is why you might see in some people with ADHD that they might look um, a little bit like they have OCD. They're going to have some OCD symptoms. So very forgetful. Did I turn the coffee pot out off? Oh my goodness, I'm gonna burn the house down. Did I lock the door? What did I just see on the side of the road? And it's because they're never present, and they're not present because, excuse me,
Bless you.
Bless you.
they're not present because the default mode network is always churning.
Mm.
So you will see some sort of oftentimes obsessive thoughts, but typically true OCD, you're going to have compulsions or the behaviors to extinguish the anxious or obsessive thought. And you don't really see that in people who have ADHD. Now, people who have the comorbid condition of both, you will see that, but not if you just have ADHD.
Do you typically see that there is comorbidity? If there's ADHD, there is maybe something else that's coming along with it, whether it's like being in a chronic state of stress, or having previous trauma or family things going on.
Yes to all of that. um, you have a high prevalence of being quite anxious, and the large percentage of people with ADHD are going to have what I call significantly existential episodic brooding, which means every now and then, most of the time they're fine, but every now and then they're going to go into kind of sort of this dark place, and they get oddly existential sometimes. Lots of thoughts of death. What's the point of anything? You see people go through these cycles, and that's why they're often sometimes diagnosed with either unipolar or major depressive disorder or bipolar disorder, because they do have these periods where they feel elevated and they feel like they want to get everything done, but it's not a true manic episode. So you see a lot of that. You see a lot of people with ADHD having a lot of somatic complaints, a lot of neurological stuff. You see a lot of GI problems with people with ADHD. And most people with ADHD have a traumatic childhood. Now why though? All right, there's a directionality problem there. Is it because they were traumatized and they developed ADHD, or is it because their parents had ADHD, they weren't good at emotional regulation either, and then therefore you can see how complicated that can get.
Yeah.
Particularly in the light of the fact that it's polygenetic, meaning there's no one thing that we can point to definitively and say, that's it. This person's going to have ADHD. There's no doubt about it. We have not found that to be true yet.
Interesting. I always find it kind of, I guess, just fascinating when you find something like ADHD, and then you mentioned that you notice like the gastrointestinal issues that people tend to present with as well. Do you think that could be as simple as it just comes with an elevated level of stress, and the stress will have impacts on various areas of how you function? Or do you think it's actually correlated to the ADHD in some way, and it's not just stress's impact on the body?
So we all have it, right? So have you all heard of a guy named John Kabat-Zinn?
Mm-mm.
He wrote a book called Full Catastrophe Living, and he developed a way of working with stress called mindfulness-based stress reduction. And it's a pretty great program. But I heard he was being interviewed one time, and he said, we've got to learn how to be less reactive to stress. You never hear him say we need less stress. So it's not really that people with ADHD have any more stress than anybody else. We all have it. It's just that they're more reactive towards it, right?
Yeah.
And let's say you're 3 years old. We already know that ADHD starts really early on, and you're feeling that external stress or even internal thought, because you've got that default mode network that's churning, you're having some sort of anxious thoughts or something stressful is going on in your environment. These people are more sensitive to it. And you don't have the cognitive abilities to go and talk something out. So you start from an early age really internalizing and somaticizing stress. And I happen to believe that most people who have these really strong somatic complaints that have ADHD or any other mental health diagnosis, that it's typically due to adverse childhood experiences at a really developmentally early period.
Interesting. So kind of moving us into a specific topic about ADHD and how it presents in adulthood. So someone in their early to mid 30s or later, where they've never actually had a noticeable issue with, I guess, their ability to focus on specific tasks, or their ability to not ruminate on these things and actually multitask in a productive way. Are you seeing an increase in adults coming in with like newly onset symptoms or newly aware of those symptoms? And what does that normally look like? Like as an adult, what would that look like if you're starting to feel some of these, signs of ADHD that you may need to go talk to somebody so that you can get a hold of them?
Well, at my practice, I only work with adults, so I can't say there's been an increase in
Okay, good.
in that. So I for a short time, I was doing some med management for a residential treatment center for teenagers, and so I have worked with teens and some adolescents before. But most people will come in and they'll preface the conversation with "my partner said," or
Mm-hmm.
or "I'm stuck." I really I want that job promotion, but I can't get it. Or I can't hold a job. Or I go through jobs like dirty dishes.
Hmm.
So this inability to get any kind of traction in their career. And then oftentimes, almost always, that is accompanied by some kind of emotional dysregulation. It's always there. It looks different in everybody. Some people blow up, some people shut down, some people get really anxious, some people get really sad and depressed. It's always there, though. Russell Barkley is one of the greatest experts in ADHD in the world. He has a talk. You can watch this on YouTube. I think it's on that channel called Attitude, ADDitude, and it's called deficient emotional regulation, the often overlooked ADHD symptom that impacts everything. That's a mouthful, but if you go and you listen to that, you'll see what I'm talking about, and that kind of leads us into this newer term that we're using called rejection-sensitive dysphoria.
Hmm.
And you cannot be diagnosed with ADHD because you have RSD. So these people who have ADHD who also have this RSD, which is a lot of overlap, they tend to completely wilt whenever they feel criticized or evaluated, or they lash out, or they get anxious and they ruminate over the conversation. Oh my gosh, that person doesn't like me, and it's very much freeze dried, meaning they could be washing the dishes, doing something that doesn't require much from the task positive network, and so we already know what's going to happen. The default mode network's going to rev up. It's going to pull up a memory from 15 years ago about an embarrassing social situation that they had. And then the person goes, where the heck did that come from?
Mm-hmm.
Right? And it's just endless. And what that does is that causes a lot of stress on the symptom. You're already more sensitive to that stress. So being sensitive is a double-edged sword, right? So we talked about how a lot of people with ADHD are creative types, so they need that sensitivity, but it comes at a cost.
I think Tony's smiling because you're both like describing me.
Yeah. Well, and me. That's why. Yeah.
I am one of the. I think I'm going to be one of the like later in life ADHD victims. It doesn't show up in my work life at all. I'm very well structured in my work life, and it's post work and kind of impersonal time.
So the environment is conducive to the trait.
Mm-hmm. Yeah.
Yeah.
So but the rejection sensitivity, I've heard rejection sensitivity before, but not in like this conversation with ADHD. That's really interesting.
It's significant. It's significant. And we do have some medications that we can prescribe that can be helpful. I'd say in my clinical practice, I see about 2/3 of people respond favorably to what we call an alpha-2 agonist, which is a fancy way of saying a blood pressure pill, believe it or not.
Hmm.
It tends to, but here's the interesting thing about an alpha-2 agonist. They cause vasodilation, so they make all your blood vessels kind of open up. But the effects of how they work in the brain on rejection-sensitive dysphoria or emotional regulation is a mystery. Nobody really knows. We have theories. But if you give somebody one of these medications, clonidine or guanfacine, aka Intuitive, those are some examples, in some people, they will notice, and it's usually not a quick fix, but they will notice that they feel a little less emotionally reactive towards stress in their life. And that I like those medications because they're not habit forming. At the lower doses, you could discontinue them anytime you want, and they're readily available. And a lot of people, I'll say, before we start giving you a stimulant like Adderall or Ritalin, why don't we start with something like this, and let's see if this helps your emotional regulation, your reactivity to stress. Let's clean your diet up a little bit. Let's have you do some of these breathing exercises for 3 or 4 weeks. Come back. If that's not enough, then we can talk about something else. But that emotional regulation, I think, is the linchpin, because if you're not emotionally regulated, your executive functioning fuel tank drains really quickly.
Mm-hmm.
And it takes a lot longer to refill it if you are neurodivergent.
Yeah, that is interesting. I worked for a little over a year in a private practice when I lived in Illinois as just a mental health therapist, and there were not a lot, but there were a handful of kind of teens that would come in, and when discussing their medication, I would Google some of their medication. I'm not, really in tune with the majority of medication or management like that, but when I would look up Clonidine, was it Clonidine or Clonopin?
Clonidine. Clonopin is a benzodiazepine.
I was going to say that's a different one.
Yeah.
I would Google that one, and it would show up as a blood pressure medication, and I was very confused where the connection or the correlation was. So it's interesting to hear you talk about it.
Many times in psychiatry, things are used off-label. Things get repackaged and repurposed. I mean, lithium for bipolar disorder, it's a metal. We're going to put some metal in your body and it's going to make you feel like you're less manic. Like, explain that. Um, we use anticonvulsants. So, for instance, my mother has ADHD and she also has epilepsy. So she's the poster girl of neurodivergence, and she's on an anticonvulsant for her epilepsy, right? But we also take that exact same medication, lamotrigine, and we give it to people who have mood disorders.
Wow.
So we do this all the time in psychiatric med management. Did you guys want to talk about the role of stimulant medications?
I do. Before we get there, though, since we're talking about just how it presents in adults, can you talk a little bit about the difference in presentation in men versus women?
Is there one?
Or is there one? That's been a question we've gotten a few times about women, adult women, how they're starting to feel as though they do in fact have ADHD, but they never cataloged it as that until they learned more about it, and its kind of unique presence in women.
So you will hear it's often said that women tend to be more inattentive and men tend to be more impulsive or hyperactive. But that story starts in childhood. So if I were to come over here and I got my computer pulled up, I've got this thing called the Winder, Utah Adult ADHD Rating Scale. I've got a guy I'm gonna meet with him at 11 o'clock. He thinks he's got ADHD. We're gonna go over this. It's got like 60 some questions, and it says, as a child, I was or had. And you'll have to go back and think about like early, like middle school, maybe. That's what I tell people to think. And you will see that trend. It started really, really early. You'll see girls answering, females will be answering the questions in a way that it's going to indicate there's a lot more inattentiveness, staring out the window, zoning out, daydreaming all the time. And then men in childhood are much more likely, they will sometimes have that, what we call the combined type, right, where they have that, but they're going to be impulsive, hyperactive, wormy, things like that, fidgety. And you often see more of a convergence into inattentiveness and, of course, the emotional dysregulation piece in adulthood for both.
Mm-hmm.
So you do see, statistically speaking, men are a little bit more likely to be impulsive, but the hyperactivity usually burns itself off for some reason. There's a lot more inattentiveness, and then women predominantly inattentive.
Interesting.
But of course, not always, though. So I don't really even know what the value of that is. You just have to stick by the book, and these are the observable diagnostic criteria, and you either have them or you don't, and the gender is maybe not so important.
Yeah. And would you consider one, like the inattentive would be more internalizing, and then the impulsivity would be more externalizing behavior, the observable?
Yeah, that's exactly right.
Okay.
Interesting.
Yeah.
Okay, so there's not really, and I think this is some of the question that people tend to have is, from a diagnostic perspective, what those variables were based on was on, I'm guessing, assessment of men primarily when they were written.
Like the original one?
Yeah. So like,
where did it come from, right? So originally, if we go back to the early 1900s, I've got a slide on this somewhere. Presentation that I did for therapists, teaching therapists how to work more effectively with clients with VAST or ADHD. Where did it start from? It started with a doctor, a brain surgeon, noticing that after something called a pneumoencephalogram, so they used to pump, this sounds barbaric, but they used to pump air into your head to squeeze your brain to make the structures more visual on a radiograph or an x-ray. But that comes with lots of side effects, right? One of those would be headaches.
Yeah, I'd imagine.
So they're giving kids these pneumoencephalograms because they think maybe they've got a brain tumor. We want to see if we can, we want to be able to image that. And then, of course, there was nothing like a PET or an MRI, anything like that. These are just the X-rays. And so to offset the side effect of the headache, he would give them amphetamine. And what he noticed is all these kids calm down.
Hmm.
So before there was a diagnosis, there was a treatment that informed a diagnosis.
Interesting.
Mm. And the amphetamine is still the piece of the stimulant that we use today.
That's correct. There's several different types. So essentially what you do when you give somebody an amphetamine, and there's lots of different names, right? Everybody's heard of Adderall. It's a mixture of two, amphetamine and dextroamphetamine. Then there's dextroamphetamine. There's Vyvanse, which is lisdexamphetamine, where you take a lysine amino acid molecule, you stick it on an amphetamine, and it changes the profile of the release. But it's still, at the end of the day, it's just an amphetamine, so it's important for people to know what it's doing. So what is it doing? Why does it make ADHD symptoms? Why does it improve them? And the theory is that it's increasing the amount of dopamine and norepinephrine in the brain. And it does that through two different mechanisms. It sort of squeezes and forces the hindbrain to produce more dopamine.
Hmm.
And it also blocks the reuptake. So what it does is it paralyzes these protein transports that move norepinephrine and dopamine back and forth between the neurons. So in a sense, you could say that it is clogging the bathtub and turning the water up on high, turning the pressure up. Whereas methylphenidate or Ritalin is just clogging the bathtub.
Hmm.
So it blocks the reuptake, right? But it doesn't force the brain to produce, stimulate the brain to produce more dopamine. And so we need norepinephrine for focus and concentration and learning. And you need dopamine for drive. So when you feel really driven to do something, that's an increase in dopamine.
Interesting. So, what's your stance on prescribing based on what you've seen from a success perspective on prescribing people with ADHD on putting them on stimulants?
Mm-hmm. Yeah, well, to answer that more fully, you have to know something else about stimulants. Many people will come to me and they'll be on 50, 60 milligrams of Adderall, which is a ton.
Wow.
It's a lot. It's a high dose. And the story of how they got there is always the same. They started with 10. There was an instant rush of utility and well-being and euphoria even. So when people first get on this, or they'll come in for an intake and they'll say, "I know I shouldn't have."
Mm-hmm.
And then after that comes, "But I took my friend's Adderall and I almost cried because I was like, oh my God, I never felt like this before." I pump the brakes. I say, "Stop. You cannot rely on that." And the reason you cannot rely on that is because your brain is naive to that much dopamine. Anybody would feel that way if they took 5 or 10 milligrams of Adderall. They never had it before. So essentially what happened was you had these dopamine receptors, but you had so much more dopamine come in that they couldn't handle it all. So you feel super driven, you feel really positive, you feel really happy, all the things, but your brain does something and it does it at a breakneck pace. And that thing that it does is dopamine downregulation. And this is the primary weakness or limitation of a stimulant. All these receptors the brain goes, oh my goodness, we didn't have enough receptors. It's almost like too many cars showed up for the parking lot. So the brain builds more parking spaces rapidly over a course of days. And so that dose of 10 milligrams, which felt amazing after as little as just a few weeks, is just fine because the brain habituates to it, right? So now you've got all these new dopamine receptors that need to be fed. And so now you need more dopamine. And so it's an endless cycle. So what people need to know is the less often they take it, the better it works.
Interesting.
That is interesting.
But but here's the problem with that. If you do that, if you take it 3 or 4 days in a row and then you take 3 days off, a lot of people do not like the way that feels.
Hmm.
Um, but I haven't come up with a better I don't know. I don't know what the option is at this point.
So the people who are on long-term steady dosage, like if you've got somebody that's taking 20 milligrams a day for years, does it turn into more of like a placebo? Like your brain has essentially caught up and it's not actually having the same impact? Or are some people able to still kind of capture the increase in norepinephrine, but the dopamine regulation part of it's just not really what they needed because they have natural drive or they've been able to like build habits.
Yeah, that's a great question. In my clinical experience, what I see is people come in several months after they initially started and they say, it's just not doing what it was doing. That's what they
Mm-hmm.
say. It's not doing what it was doing. So how do we make it do what it was doing? I don't have people come in and say I've been on 10 or 20 milligrams forever and I've taken it 7 days a week for 5 years and it still works.
Hmm.
Yeah, I've never heard that. It's
Interesting.
always, it's not doing what it was doing. And so most prescribers will make this fall in this very seductive trap of just increasing it.
Yeah.
Now you can to a certain point, but there comes a point where you got to say, look, maybe it's time for you to go off of this for a while. And we do have other dopamine increasing. We have a medication called Wellbutrin that increases dopamine, and you can stay on that for maybe a little bit longer. But you still have people who use that for ADHD symptoms. You still have them complaining and saying it's not doing what it was doing. And so then I say, well, I'm gonna give you sort of I'm gonna give you the technical explanation, and then I'm going to give you an example from your life to show you how dopamine works. So what a lot of people don't know is dopamine is rapidly being broken down and turned into norepinephrine and then being excreted all the time, all day, every day, while you're asleep, whether you're awake. So it's very much like a slippery bar of soap. The brain loves dopamine, but it cannot hold on to it. If you go down to an ice cream shop near your house and you get a scoop of vanilla ice cream, whatever. So my favorite is butter pecan. So I'm gonna go down there. I'm gonna get the ice cream. The first bite is what?
Heavenly.
Yeah.
It's rapturous. You love it. You're like, oh my God, it's amazing.
I like that. Yeah.
What's the eighth bite like?
Feeling
Same.
bloated. And, yeah.
Not like the first, is it?
Yeah.
Yeah.
Okay. Your team wins the Super Bowl. How do you feel?
Pretty amazing.
Mm-hmm.
If you're a Buffalo Bills fan, you're probably partying in the streets, right?
Yeah.
What about the week after that?
Yeah, it depends.
I don't know.
Yeah. But still,
Yeah.
not as great as when they win. Yeah.
Yeah, so we call this thing in positive psychology, we call it hedonic adaptation or the hedonic treadmill. And so we are always adapting to things that bring positive emotion at breakneck speed. And part of that is because the brain rapidly habituates to dopamine and then deletes it.
Interesting.
And there's no difference between that and a medication. The medication is just giving you much more. But you will at some point habituate to it and it will become the new normal and you will be able to derive no more perceived benefit.
So Jen and I had a conversation about this recently and you had touched on this a little bit when you mentioned get their diet right. It's kind of like this chicken or the egg thing where if you have someone who feels totally unmotivated and as a result of feeling unmotivated, you're not doing the things that would kind of stimulate you to continue doing the things that keep you motivated. So you're just like in the basement. Do you recommend trying to do like what I would call just control what you can control? So before you get on medication or anything like that, let's look at what you're eating. Let's look at how you're sleeping. Let's look at your social life. Let's look at all of these things that will create the same type of internal chemistry that you need to be able to feel motivated, to be able to concentrate, to be able to feel, happy about yourself and about your life. Is it something that you would recommend focusing on those baseline controllable behaviors before getting on a medication, or do some people need the medication to be able to
kickstart
the process? Yeah.
Yeah, you get people in both camps. Yeah, I tell people with ADHD, if you can't do anything else, if you can get your heart rate up outside for a few minutes a day, that will build on itself. So we know from a study in 2016 that was done in Spain with people with ADHD that if you get them exercising and doing cardio more days a week than not for at least 20 minutes, it increases a substance in your brain called brain-derived neurotropic factor. Brain-derived neurotropic factor causes something called dendritic lengthening or thickening. So dendrites are the little protrusions off the neurons. and this factor causes them to grow longer and thicker. And we've seen in behavioral studies with mice, when you give them ketamine and you grow their dendrites longer and thicker, their survival response goes through the roof.
Hmm.
You put them in a pool of water, they swim, they quickly give up. You give them a little bit of ketamine, a week later, they just don't stop.
Wow.
So does everybody need ketamine that has ADHD? Absolutely not. But we could get something very similar if we could just get our foot in the door with getting our heart rate up
Interesting.
outside, because then you get the double benefit of serotonin support from that. So if you can just do that, that's great. Or let's say they can't clean up their diet to start with, but they could include more medium chain triglyceride fats, for instance, MCT oil, coconut, avocados, walnuts, macadamia nuts, those types of things. Where the other pistachios are a good source of it. So Dr. Stephen Gundry, who's a cardiologist and a nutritionist, he found, this has probably been like 7 or 8 years ago maybe, that if you eat medium chain triglyceride fats during the day, that your body likes to turn them into ketones, whether you've been eating a ketogenic diet or not.
Hmm.
And the reason that is important is because if you can get ketones going into the mitochondria, they were a biochemical messenger. And the message is replicate. So if you have more functional units that you are spreading the burden of metabolism over, let's say you've got 1,000 mitochondria in a given cell, and after you eat a bunch of MCTs after the course of 3 months, you've got several million. Well, now those cells are working much more effectively and efficiently, and you also have those cells, those neurons would be those cells as well. So you're getting the benefit from that. Your brain works better.
So if you get somebody on a medication then at the beginning, like they're not going outside for 20 minutes. They're not going to change their diet. They are just not zero motivation. If you get them on a medication to kickstart and then they build these habits, do you find that people tend to be relatively successful and then weaning off the medication and just like keeping with these routines?
You do see it, and you see it if they're able to do that and cut back a little bit, because it's just such a complicated picture. Remember, go back to the RSD part. People who have ADHD can't say no.
Mm-hmm.
They don't have boundaries. They just give and they give and they give, right? So now they're overscheduled, overcommitted, overworked, and now they're stressed, and now they need the medication. So this is why it has to be attacked from so many different areas.
What you said? So it's the rejection sensitivity. What was the last? Is it
Dysphoria.
dysphoria? Okay.
Now there's a newer term that doctors Rady and Hallowell coined called response recognition euphoria.
Hmm.
This is the other side of the coin, right?
Mm-hmm.
So like with the default mode network, on one side of the coin, you've got rumination, anxiety, fear, loathing, disaster. On the other side, you've got I wrote a novel. Right? So it does both. The default mode network is responsible for both. So on the other side of uh, emotional ruin because of RSD, you have people with ADHD who feel pumped up on the regular tend to do really well. Which I don't know if there's time to talk about coaching today, but I happen to believe that ADHD coaching is really, really effective if it's done the right way, and sometimes much more effective than like traditional psychotherapy,
Hmm.
because there's nothing to fix. There's just something to augment.
Yeah.
Interesting.
I'm a big fan of executive functioning coaching, and just its kind of behavioral approach versus, like you said, the psychotherapy where you're pathologizing behaviors or brain processes. And I like that's something I haven't found here in at least in the Wilmington area of just an executive functioning coach rather than go to therapy and talk with this therapist. I think
Well,
in Illinois there's more executive functioning coaches I've come across.
you might see some, but you're not going to see many. And the reason is because our society, we don't, you're supposed to, first of all, counseling's taboo as it is. But if you have a problem, you go see a therapist, you don't go see a coach. But with people with ADHD, coaching is more effective because ADHD is not a knowing problem. I'm starting some ADHD coaching myself, some executive functioning coaching, and I had a guy, we did a consultation about 6 months ago, and I give all the information they want. We're talking for an hour, free. I just give it away. And he's writing down in his notebook. And I just said, how many of those notebooks do you have? And he said, I got a lot, man. I know a lot about ADHD. I was like, so what does that tell us? It tells us that this is not a deficit in knowledge. You know what you need to do. This is a doing problem. You just won't do it. You're not gonna, I'm gonna give you all this information. I'm not trying to be pessimistic, but you're not gonna do any of it.
Mm-hmm.
Then you need a coach, a body double, a coach, something like that. You need somebody that is helping you hand over hand with very pragmatic skills until they become a reflex. Not a habit, but a reflex.
Yeah. And I think Tony and I have had like very similar conversations of like, I know these things. It's a matter of initiating, and it's a matter of doing. And I find that body doubling is one way that I like actually get up and go and do.
It's the same concept with people who struggle to get in the gym. They have a gym membership. They read all the things on diet. They do all the things on all the workouts. They know all the things they need to know, but they don't go to the gym.
Yeah.
So getting a personal trainer is the only way to get them in there, to keep them on track and doing the right thing. It makes a lot of sense.
Yeah, until they're disciplined enough to do it on their own. And I like to take this word motivation, throw it out the window. It's a terrible word. It should never be really used when it comes to trying to build helpful habits. Because if you take the most successful or productive people in the world, they have many times during the day where they don't feel motivated. They don't feel like doing something, but they do it anyway. And it's because they've built discipline, which is static, where motivation is not.
I like that.
Yeah.
I think I've mentioned discipline to you in ways too of like, it's not a matter of being lazy or not caring or not being motivated. It's a matter of discipline. And I think discipline goes along with like awareness and kind of self-love. And if you have a good sense of self and a sense of core values and you're in tune with that, you are more inclined to find ways to discipline yourself to get those habits going.
Yeah.
But I like the idea of throwing motivation out the window. It's
not useful.
It's not useful. It's harmful to say like, I'm not motivated.
That's why that idea of like the habit circuitry of forcing yourself to do it over a period of time, and then it does just becomes a discipline. It becomes something that this is going to happen, and you slowly do start to see how it makes you feel, the positive rewards of doing the thing that you didn't want to do, but once it's done, you feel better. So it kind of builds on itself.
Yeah, and you've got to take this approach. So when I talk to people with ADHD about building discipline, I use two examples. One of them is a Super Mario Brothers game, because most people I'm working with are old. I mean, let's say even kids know what Super Mario is, right? Yeah. So Super Mario Brothers and brushing your teeth, right? So we start with Super Mario Brothers. World 1, Level 1. Every world, there's 8 levels, and they all have 8 worlds, and they all have 4 levels, right? Well, you don't get the flying turtle thing until like level 3. And the reason you don't is because you got to deal with the Beetle Bailey first. Like, you have to learn this skill before you can learn this skill, and it builds like a layered cake. So people come in with ADHD, they got this all or nothing thinking. I cleared out the fridge. I got all this new stuff. I cleared out the cabinets. I got rid of all the processed carbs. I was like, let me guess, the stuff in your refrigerator rotted. Absolutely it did. How'd you know that? Well, it's because you have this all or nothing thinking, and you're trying to play chess when you can't even understand checkers. So we have to start at World 1, Level 1, and we get you filling up your partner's Nalgene bottle every morning. That's what you're going to do. You're going to do that for the next 2 weeks. When you feel like that is ingrained, we're going to add something else on top of that. This is why they need a coach, because left to their own devices, they will try to go all out again, and they will give up. And they will see a pattern in their life of this up and down, unrealized expectations, hopes, dreams, and goals because of that all or nothing cognitive rigidity. So we have to start with level 1, World 1, Level 1, and slowly build ourselves up, whether we feel like it or not. The other thing is, I don't know anybody who gets out of bed in the morning, gets out of bed in the morning and does a backflip because they're so excited to brush their teeth. I also don't know anybody who gets out of bed in the morning and is really upset while because they have to brush their teeth. I'm crying because I have to brush my teeth. You never heard anybody do either one of those. So highly ingrained reflexes really don't have a lot of emotional charge to them. And that's how I know when somebody's ready, when they don't really think one way or another about it. It's just something that they're doing and it's on autopilot. So a level of emotional neutrality is actually good for the ADHD coaching client because they tend to experience such strong polarities of emotions anyway. So this regulation can feel a little bit boring.
I like that. I know we're at the hour. Do you have like 5 more minutes? There was one question I wanted to ask, and
Yeah, sure.
it was about medication.
Well, there's also maybe there is another conversation to be had here too, because I think that talking about some of the popular vices that people with ADHD tend to be attracted to, or the whole population, alcohol, so ethanol, nicotine, caffeine, there's a lot to be said on how those affect the ADHD brain, mood, mindset. So maybe that's something we could talk about in the future.
Yeah,
But it's
absolutely.
important because most people are drinking alcohol, most people are drinking caffeine, and some people are using nicotine.
Yeah. Well, it makes sense too with caffeine. If it's like it's giving you energy, it's giving you drive to try to find that motivation that we're not going to be using anymore. But that concept makes sense with all of those vices. My question, I guess, is kind of two. One is, I had somebody reach out to me, and she had specifically asked us to have a guest on like you to talk about this topic. But she said that her mom is on Ozempic, and her doctor was telling her that Ozempic, the obvious use for that is weight loss, but they're starting to see some benefits, kind of like what you talked about before with psychiatric medication with people with ADHD. So it's having a positive impact on their ability to focus, to multitask, to find drive. I was curious if you've heard anything about that drug specifically with regards to ADHD application.
Nope, but you've got me. I'm going to have a little time after this.
I'd never
I'm
heard of
trying.
it either. Yeah.
I don't know how semaglutide, which is the chemical, I don't know how that would. I'm curious.
I mean, I think it makes sense in the big picture of if somebody if they're struggling with their weight, they're starting to lose weight, they're finding confidence, they're finding motivation in areas and ways that they didn't have it before, and maybe that's manifesting in various other places within their lives. So maybe that has an impact, but
Maybe it's chemical.
yeah,
Yeah, it's gonna have something to do with dopamine. So more dopamine isn't actually always better. Um, it's so sometimes you need less. And so what happens with you were just talking about caffeine. If the caffeine consumption comes down, we get more adenosine rushing into our brain, which makes us feel tired, which we need. So caffeine is an adenosine agonist. It looks just like this little amino acid that's floating around in your brain, and it blocks the receptors so that adenosine can't attach. So caffeine does not give you energy, it blocks your ability to feel fatigue, which you then interpret as energy.
interesting.
But the problem there is it wears off, the adenosine rushes back in around 2 o'clock, and now the person has this low.
Yep.
And this is a person who already struggles with emotional fluctuation. So that's the last thing we want, is to continue this roller coaster. So maybe Ozempic is uh, antagonizing the dopamine a little bit, and that might actually make people be reaching for dopamine seeking behaviors less. I don't know. I'm gonna have to look that up. That's interesting.
The second part to that is the traditional medication, which is the stimulants. What you hear people on these massive doses, like 60 milligrams, like you had referenced, and
80 sometimes.
I know some people that have been on since college, so almost 20 years on that high amount of medication for a stimulant. Are there studies at this point in time that are longitudinal that show long-term impacts of being on a stimulant?
No.
That's wild. I mean, are there concerns in your line of work of just like from what you know about how medication and how stimulants impact people that there could be some long-term negative impacts?
I think so. Nobody's going to convince me that paralyzing protein transport for days and years on end isn't going to have consequences at some point.
Yeah.
Forcing the hindbrain to produce more dopamine when it doesn't really want to. I don't see how those are good things for most people. So I think people need to be on as small and then the smallest effective dose possible, or they need to find another way. I don't take ADHD meds. I don't like the way they make me feel.
Yeah.
And I do the opposite. I try to reduce, if not completely get rid of, eradicate all the things in my life that cause an artificial stimulation and dopamine.
Hmm.
Because what you're really doing when you're giving somebody a psychiatric med, period, is you're taking away a little bit of their power.
Hmm.
The message that I'm sending to you is that you don't have everything that you need within you to flourish. Therefore, you need to take this thing from the outside and put it in you, and now you're enough.
Yeah.
And people, I don't think they understand the significance that can have, the impact that can have on us. So I want to empower people. Do we need to do some meds at some point? Yeah, maybe sure we do. But we've been doing these other things, and it's a mosaic. It's a puzzle of different things. Have we been doing the lifestyle changes? Have we been doing a little bit of have we been getting our respiratory rate down? And there's probably an hour to talk about respiratory rate and what that has to do with rumination and anxiety and
Yeah.
CO2 and all these things. But there's lots that they could be doing that they can do that they don't need a therapist or a doctor to help them with, that they can feel personally responsible for and see success in that. And that's the definition of empowerment. And that's where we need to be starting.
I love that.
Yeah. I feel like we could take this on so many different tangents and
Yeah.
talk for hours. I feel like, Bennett, we may see you in the future
Yeah.
for another conversation.
Yeah.
Yeah, I love talking about so I'm a really avid rock climber. I'm leaving at 2 today to drive to Kentucky, and I'll be there until Sunday. And
Wow.
Oh, wow.
that incorporates a lot of those facets of mindfulness, the balance, the coordination. And there's a reason why people with ADHD are drawn to things like that or yoga. But there's a lot to be discussed about what you can do outside of the medications because it's considerable.
Yeah, definitely.
I like that.
We'll bookmark it for sure. Well, thank you so much for taking time. I know we went a little bit over, but this was very enlightening. And I could see us reaching out to you again to see if you want to have another conversation. But
Yeah, I'd love to.
Thanks for joining.
Yeah, thank you so much.
Yeah, thanks for having me. I hope you guys have a great weekend.
Yeah, you too. Thanks for joining us on another episode of Tell Us More About That. Don't forget to subscribe on whatever platform it is that you're listening to us on, and also leave us a rating and review.
If you have any topics you would like us to consider, if you have any feedback or commentary, only if it's positive, please visit www.tellusmoreaboutthat.com.
Thanks again for joining in, and we will see you next time.
See ya.